Good afternoon, everyone. Welcome to today's Public Health Ontario Rounds presentation, which will be on coronavirus in the urban built environment, or CUBE, evaluating the use of environmental swabs for the detection and surveillance of SARS-CoV-2 in school and congregate settings. My name is Leanne McDonald. I am a public health physician here at Public Health Ontario. I'm really pleased to be moderating today's session, which promises to be interesting. I do have a few housekeeping tips to get started with before we launch into the presentation. So for those of you who are new to our PHO Rounds platform, we will have the chat pod disabled in order to limit distractions during the presentation, but we do encourage use of the Q&A pod if you have questions during the session, and we will have a discussion and a question period we look forward to following the presentation, so please do enter your questions for that component of it. If you do have any technical issues during the session, please email capacitybuilding@oahpp.ca. And as moderator, I'd like to share my disclosures, which are that I am an employee of PHO and a co-applicant on CIHR funded grants. Before I introduce today's presenters, I also want to start us off with a land acknowledgement. We wish to acknowledge the lands and waters of the traditional, unceded, and treaty Indigenous territories on which Public Health Ontario operates. We respect and appreciate Ontario is now home to many diverse First Nations, Inuit, Métis, and urban Indigenous peoples and cultures. We are grateful to have the opportunity to work on this land. So now I would like to introduce today's speakers, Dr. Caroline Knott and Dr. Michael Froelich. Welcome. Dr. Caroline Knott is an infectious disease physician and director of the Antimicrobial Stewardship Program at the Ottawa Hospital. She completed a Master's of Epidemiology at the London School of Hygiene and Tropical Medicine. Dr. Knott has supported the Ottawa Hospital Infection Prevention and Control, or IPAC, and occupational health departments as a COVID pandemic support lead since April 2020. And Dr. Michael Froelich is a board-certified general internist in Canada as well as the US. He completed a Master's of Science in Clinical Epidemiology at Harvard University, as well as a PhD at the University of Toronto. During the COVID pandemic, he shifted his research focus to pragmatic clinical trials. And currently, Dr. Froelich is a clinician scientist at Sinai Health in Toronto, as well as assistant professor at the University of Toronto Faculty of Medicine. So welcome, Dr. Knott and Dr. Froelich, and over to you.
Thank you, Leanne. Mike and I are speaking today on behalf of this group that you can see here. We call ourselves CUBE, COVID-19 in the Urban Built Environment. And so we want to thank all of our collaborators as well. Thank you. I have no disclosures, and Dr. Froelich is there. So what we'll be talking about today is how surface sampling for SARS-CoV-2 correlates with clinical cases of COVID-19, and then to describe how we might use these results for early identification of cases and outbreaks in other places like long-term care homes, and more generalizable from there. So I think at this point in the pandemic, most people are quite familiar with wastewater sampling. If you think about, which is really fantastic, and we consider surface swabbing to be complementary to that, both being environmental methods of detection of SARS-CoV-2. So while with wastewater sampling, there is a fair bit of logistics and equipment involved, and generally speaking, it's used for regional SARS-CoV-2 detection, perhaps at the level of a city or a neighborhood, and perhaps you could even get down to the level of a building. And we did do that with one of our campuses at one of the hospitals here in Ottawa. But where surface swabbing can be complementary is that, so it's very simple. It's just the swab that you see here with some medium that is stable at room temperature. And the actual swabbing is very simple. We've trained lots of people to do it, and it takes less than a minute per swab per sample. And it can be very spatially refined. So whereas, I said with wastewater, you might get down to the the spatial refinement of, say, a building with surface swabbing, we can find out what's happening within that building. So you could think about, each classroom within a school, or each ward within a hospital, or each floor within a long-term care home. So those are kind of the main advantages, I suppose, of surface sampling, are that it's simple, easy, relatively quick to do, and very spatially refined. And all of this is predicated on the idea that our respiratory droplets and aerosols eventually settle to surfaces. And so then we can pick up viral particles on surfaces, and then try to detect RNA through a PCR. So we were getting actual cycle thresholds with a positive or a negative result for our studies. So I'd just like to introduce the very first study that we did, and actually this goes back to the fall of 2020. So over 10 weeks in the fall of 2020, we decided to sort of test this hypothesis that we could recover SARS-CoV-2 from surfaces, and that it might correlate with human cases. And so at the Ottawa Hospital, across our 2 campuses, which encompass about 1,100 beds, we set out to do this. First, there was a component of lab-based validation. So could we actually recover viral RNA from a variety of surface types? And yes, we could. And what were the limits of detection? So that was the sort of preliminary lab work. Then we went out through the 2 campuses, and we were testing all sorts of areas. So first of all, in terms of surfaces, we wanted to test high-touch surfaces, so things like computer keyboards, telephone receivers, elevator buttons, door handles, as well as floors. And then in terms of the types of areas we were looking at, we were not in patient rooms, but we were in so public areas, some healthcare worker only areas, some COVID areas, so things like places like the urgent care in the emergency department, the COVID units, and the COVID side of our ICUs, as well as non-COVID inpatient units. And so our findings really were that, yes, we could recover the viral RNA, and far and away we recovered, we had positive samples from the floors over high-touch surfaces, which in some ways was reassuring to the people in those units. And it really, we just think that it represents, the floors represent the ultimate sink for viral particles. The floors in the hospital were being cleaned daily according to provincial, IPAC best practices. But floors seem to be certainly the marker for SARS-CoV-2 over high-touch surfaces. The next thing we found was that we actually, we had positive samples in the COVID areas. So I mentioned that we looked at urgent care, in the emerge, the COVID side of the ICU, and our dedicated COVID units at that time. And that's where we found positive samples. And we did not find at that time, in fall 2020 anyway, we did not have many positive samples in public areas, healthcare worker only areas, or the non-COVID inpatient units, except for one non-COVID inpatient unit where we detected positive swabs during the weeks of an outbreak, not before the outbreak and not after the outbreak. And finally, we did find an association between the rate of positivity of the floor swabs and both the hospital wastewater signal at one campus and inpatient COVID activity. So I'll show you that in the next couple of slides. So this is the proportion of hospital floor swabs positive for SARS-CoV-2 in the bars that you can see. And then, Mike, if you enter again, the line is the hospital COVID cases. We did take the hospital as an aggregate because rather than individual units, because at that time, once a patient was identified as COVID positive, they were moved to a COVID unit. And of course, once a healthcare worker was identified as positive, they would have been removed from the environment. So I think you can see just visually that it tracks, at least it correlates. And then we were fortunate that at the same time that we were doing this study, there was a complementary wastewater study that was looking at the wastewater effluent from one of our campuses on a weekly basis. And so that also tracked for the period of time that we had wastewater with the active cases at the campus. So with those sort of 5 findings in mind, we wanted to see, are these results generalizable? Are they useful to other settings? And so the next sort of places that we went to look were the University of Ottawa that I'll talk about, and then Mike will take over with a large body of work that we did within long-term care homes. So in the University of Ottawa, we picked 6 buildings. And so some of these were residences, some were classrooms, some were more administrative type buildings. And they're busy graphs, so I apologize for that. But what you can see in the small box at the top, the little dots, the yellow dots are negative floor swabs and the pink dots are positive floor swabs. And then we, look to associate that with things like CO2 data, so for, ventilation and building level Wi-Fi data as sort of a marker of, how highly trafficked these areas were. We did try to choose high and low traffic sites within each building. And so just time frame wise, I think what you can see here where you're looking at the cluster of the pink dots is that there was, quite a bit of COVID activity going on in early January, which makes sense. And really, there wasn't a lot of anything going on in December when, people would have been away from the university at that time. So what this slide is showing us is that in that box at the top, you can see the campus-wide COVID cases. So again, early to mid-January with a big peak there. So those are the human cases at the top, and then everything at the bottom is the floor swab positivity for all of the different, for the 6 different buildings. And then site 1 and site 2 would have represented either a high traffic or a low traffic area within those buildings. And so, I mean, I think that you can see that, so if you just picked even the very first building, so 90U, there's not a lot going on in December in terms of floor swab, or sorry, October, November, December in terms of floor swabs. So there's also not a lot of COVID cases. And then in January, when we start to see the COVID cases, we're getting a lot of floor swab positivity. So we took this data and tried to make a bit of a predictive model. So the black bars at the top of each building graph represent the predictive model. So we were able to look sort of 1 week in advance to predict cases. So the model was based on the floor swab positivity, with the outcome being human cases. But we were able to make predictions which were valid based on the floor swab data only. And so again, if you just took 9DU, which I think is, a pretty good representative one, there's this in the middle, you can see the pink cases. So those, there's a big cluster of cases in early January. You see a lot of floor swab positivity. And then the model was able to predict out, week by week, when there might be another spike. And then you can see in April, there actually were more floor swabs positive. And so we did the model based on that. Unfortunately, we actually don't have case data going out that far at this point, but we'll go back and do that. And I think with that, it's over to you, Mike.
Awesome. And thank you to PHO for having us. So I'm going to now sort of talk about the long-term care home situation in Ontario. And this is one of the long-term care COVID-19 trackers, which can be found online. And really, suffice it to say, as we all know, there are a lot of long-term care homes in Ontario, and the overwhelming majority have experienced an outbreak, and many continue to be in outbreak currently. This work has evolved over the course of, almost 2 years, starting in Ottawa, and now in total, there are 32 sites that we are swabbing across Toronto, Ottawa, and Sault Ste. Marie, where I also work. I'm going to focus on the results from the long-term care home. So we conducted a multi-center prospective study from September 2021, and we are continuing to swab in some of the homes, so coming up on a year now. And we did once weekly swabbing, in general 10 to 24 swabs done per building, depending on how large the building was. We also took carbon dioxide readings from half of the homes at the same place where the swab was done. And the idea there, of course, is getting a sense of what the ventilation was like, CO2 being a surrogate for ventilation, with high CO2 suggesting poor ventilation. And then we had outbreak data reported from the long-term care homes, and we could corroborate that with what was available and reported and publicly online. So this is one of the very first homes that we swabbed. That's me, and then Ashley and Benna, two of our team members. In the top left corner, just sort of a map of the building. And on the first site visit, we would meet with the manager of the long-term care home, as well as IPAC team members, if they had them, to walk around the building and also identify areas that they in particular might have been worried about or wanted us to swab. This very fancy gadget in the middle pane looks like something from Ghostbusters. It does not collect ghosts, but it does measure CO2 levels. And then, as Caroline mentioned, the floors are swabbed, and then this information is then logged online, and the swab itself is sent to one of 2 labs where we process the swabs for PCR. And each week that we went to the long-term care homes, we were swabbing in the similar locations. So, comparing apple to apples over time. So now I'll walk you through one figure here. Let's look at one long-term care home. So on the y-axis is the number of samples or the number of swabs that were done. On the x-axis is time. At this home we started in November. The yellow bars, if it's all yellow, that means 0% of the swabs detected SARS-CoV-2. And then the red color means that SARS-CoV-2 was detected. Up in the top of the pane here, the pink line indicates that there was an outbreak that affected residents, and this sort of green line were the number of staff members that were involved. So I think what we can see here, at least, is no real outbreak when the SARS-CoV-2 detector on the floor is quite low, and then approaching almost 100% of swabs. And then you can see some improvement, and then all of a sudden, 100% of swabs are coming back positive, 80%, 90%, and lo and behold, unfortunately, in that long-term care home, they had another outbreak. Let's contrast that with another long-term care home. So again, the y-axis is the number of swabs done, and x-axis is time. And you can see, a very small percentage of swabs coming back positive for SARS-CoV-2. And in this very faint bar, the fainter the bar, the less number of infected staff members. And then we can see over time, again, very small numbers of swabs on the floor coming back positive for SARS-CoV-2. And indeed, there were some staff level cases. And then over time, we see the signal rising, and unfortunately, there was a much larger outbreak that followed. So that's just 2 of the long-term care homes. As mentioned, we swabbed at 10 long-term care homes. So let's talk now on a sort of high-level summary of the results. So we've collected just under 4,000 swabs at these 10 long-term care homes. During the course of swabbing, there were 19 outbreaks during the study period. You might ask, okay, but how big were these outbreaks? So the median size was 34 cases, and that's the range there, as small as 2 and as high as 150. For the floor swabs, so the percentage of floor swabs detecting SARS-CoV-2 was 51% during an outbreak, with pretty tight confidence intervals. And then when there was no outbreak, closer to 18%. And you might ask yourself, well, why wasn't it 0%? Keep in mind, of course, the definition of an outbreak is imperfect. And also, there might have been no outbreak, but an individual staff case here and there. And then we also might ask how well this maybe could predict an impending outbreak. So among 8 of the long-term care homes with an outbreak, where swabs were performed in the weeks prior to the outbreak starting, 5 had floor swab positivity exceeding 10%, 5 or more days prior to the outbreak being identified. And I think visually you can see that information here. So each of these blocks is a long-term care home. We have time on the x-axis and just the proportion of swabs coming back positive for SARS-CoV-2. And in blue means there was no identified outbreak, and in red means there was an identified outbreak. So here's a nice example of almost no SARS-CoV-2 being found on the floor and also no outbreak. And then we start to see rising positivity up to 50%. And then it was identified that, oh, wait a second, there's actually an outbreak. So this pane would suggest, hey, maybe swabbing the floors could give us a bit of lead time. We could walk through another example of a similar story here. We also have some long-term care homes where we just weren't swabbing before an outbreak had started. And then I think whenever you want to speculate how well might this perform or how accurate is this, we need to talk about the test characteristics. So here is our receiver operating curve. So on the y-axis is sensitivity, and on the x-axis is 1 minus specificity. If you're looking at this and thinking, what the heck is this? So what this tells us is how good is our model at discriminating between whether or not there is or is not an outbreak. So a really terrible model would fall on this dotted line. Our model has a discrimination of 0.86, which is pretty good. The best it could possibly be would be a 99%, and the worst it could be would be 50%. I think the other question you probably want answered is, all right, so if we detect a certain percentage of swabs from the floor coming back positive for SARS-CoV-2, what is the positive predictive value, aka the ability to say, oh yeah, there's an outbreak occurring, versus a negative predictive value? And obviously, as you change the thresholds, there's trade-offs between PPV and NPV. So at a 30% threshold, that means more than 30% swabs are coming back positive. That is a 64% positive predictive value that, hey, there's actually an outbreak going on right now, and an 86% negative predictive value at identifying that, it's unlikely there's currently an outbreak. And then we can also sort of stratify the results by location. So across all locations, 28.9% of swabs were positive for SARS-CoV-2, 50% during an outbreak. And this is sort of our most recent data as of a couple of weeks ago. And then how about when there are staff cases? 13 some odd percent are coming back positive, and no cases, 19%. And then, of course, you want a bit more refinement than that. As Caroline mentioned, a benefit to this approach is localization. So we could take the example of how do things look in worker-only areas, so only where staff members are, where there are no cases of SARS-CoV-2, and then when there are staff cases. So clearly you can see elevated amount of SARS-CoV-2 being detected in these worker-only areas when there are staff cases. We also looked at how does the cycle threshold change, and lower cycle threshold would mean more and more viruses present. For people who are more familiar with looking at these results from human-based testing, you'll immediately realize that these are relatively or quite high cycle thresholds. This is pretty typical for environmental sampling. And then the CO2 measurements, it was a lot of work to get those CO2 measurements. I'm not sure how much predictive value they had, but I'll also mention that with CO2 measurements in the sort of 500s, shows that these sites had pretty darn good ventilation. So it might not be that CO2 isn't useful. Instead, it might just mean that the locations where we swabbed had really good ventilation. And then next, I'll talk a little bit on how does the viral burden actually change over space and time. So in the slides so far, those were all at long-term care homes and not within the actual residence room. Instead, it was in common areas as well as the staff areas. But we also wanted to answer the question of, how about in the area surrounding a person who has COVID? So this was recently completed at 2 hospitals in Ontario, so not in LTCs, in hospitals, and it was specifically swabbing the floors around patients newly hospitalized with COVID-19 on the ward, not in the ICU, and they had to be in a private room so that we could attribute what we were finding on the floor to the individual person. So the floor was swabbed twice daily for the first 4 days at the following locations: 1 meter from the hospital bed, 2 meters, and 3 meters. I should also mention that these patients were quite sick and for the most part were bedbound during this time period. So we collected 180 swabs from 15 rooms. So 89% of the floor swabs detected SARS-CoV-2 surrounding the patients. On day 0, it was 81%, and by day 2, almost 100%. A median cycle threshold of 34. So again, it's confusing, but lower numbers mean more viruses present. So certainly we're seeing higher viral burden immediately surrounding patients hospitalized, in contrast to what we were seeing in long-term care homes, which I think is intuitive. The other question was, how do the results change over time? So this is the cycles above level of detection. So essentially, the higher the line, the more virus that's being detected. At the Ottawa site, pretty consistent over time. No clear increase in the Toronto site, maybe some increase over time, but we got to be careful to not overinterpret that. I think what was striking is certainly there was less virus being found on the floor in the Toronto hospital being swabbed. And that made us wonder, maybe the Toronto hospital's better ventilation. Nope, that was wrong. Identical CO2 measurements across the two sites. And then later we realized there were different cleaning protocols. So in the Toronto hospital, they were cleaning the floors twice a day rather than once a day in the Ottawa hospital. And then finally, how did things change sort of over space? So this would be 1 meter from the bed, 2 meter from the bed, and 3 meter plus. And again, most of these patients were bedbound. So what you can see here is that even 3 meters away from the bed, we could clearly detect SARS-CoV-2 on the floor. If we try to put these results together, we could think about the strengths of our approach. I think one strength is the size. We've collected 10,000 plus swabs and counting since starting this work. The scope, today we've talked about university campuses, long-term care homes, hospitals, and I believe there'll be an upcoming talk from our group focused on schools and daycares. I also think there's a clear strength of association, and I think that is most apparent in the long-term care setting where we know the ground truth as best we can, right? We know there was or was not an outbreak. And then spatial refinement, I think that's supported by both the hospital and LTC data. Like any study, ours has limitations. So I think the outbreak definition, of course, is going to be imperfect. That's by virtue of the fact of how this information is collected. And whether or not floor swabbing can mitigate outbreaks, the size or the scope, that's just not answered by our data. We don't yet know. We did this prospectively, but it's not like we were then giving the information to the managers of the long-term care homes to see if acting on it could make a difference. And I think with any good study, you have to ask about sustainability, right? So how sustainable is this approach? Is this something that long-term care home workers could do? Absolutely, we've shown that in the Ottawa sites, whereas at some of the other sites, we had research team members going there to swab. But I think as this pandemic continues on and on, it's important to ask ourselves, what will be a sustainable solution? What realistically could we continue to do? And I think this picture here sort of hopefully captures the fact that with the swab data, we have high spatial resolution and refinement, whereas with case data, we don't have that same level of refinement. What are the future directions? So we submitted a grant to CIHR to adapt this technique for other pathogens. I think within long-term care homes, looking for other pathogens such as influenza and RSV could certainly be important, especially in a setting of an outbreak where you're wondering, geez, is this just one pathogen? Are there multiple pathogens? We have had homes that went into outbreak, and as we were awaiting the results for COVID-19 from the individuals, we realized our floor swabs were coming back negative for SARS-CoV-2, which made us wonder, oh shoot, maybe this isn't so accurate. And then subsequently we realized it was an RSV outbreak. It wasn't a COVID outbreak. We are conducting quality improvement studies ongoing at 2 hospitals. This is led by Caroline, trying to get a sense of if you swab the floors of staff-only areas in hospitals, are you going to detect a lot of virus on the floor, which might indicate there are individuals who are coming to work who might be asymptomatic and spreading the virus unbeknownst to them. And then we have multiple grants under review. We sort of pray to the granting gods that they will continue to support our work, because we do want to shift our attention to implementation. I think that's an important unanswered question. Speaking of funders, we're very thankful for the support we received from CIHR, NSERC, and the University of Toronto. As Caroline alluded to, it's a very big team and a growing team. It's been so much fun and highly rewarding getting to work with all of these smart individuals. And it's a very diverse group: general internists, infectious disease doctors, computational biologists, evolutionary biologists, among many other very smart people. I've included my email address at the bottom if people want to reach out with questions. We were told to leave lots of time for questions, so we'd be more than happy to now try to answer the questions that people might have.
So Caroline and Mike, thank you so much for your presentations, and I am glad that there is lots of time for questions and discussion in this portion of the rounds. I will be monitoring the Q&A box, so I would just encourage everyone who is online, and we have a nice sized group today, to enter your questions and we can bring them forward to our speakers to hear their further thoughts. The first question is regarding whether the slide deck will be shared or posted. And you can see there is a note in the chat. Thanks for that question. Presentation slides and a recording will be made available, given speaker consent, approximately 2 weeks after the live session at the Education and Events website on the PHO website. So thanks for that question. So we have another question that's just come in about how early were the floor swabs able to detect cases prior to outbreaks being officially declared? I think that's a nice question because, you know, maybe it would be interesting to hear what your data reflect about when the outbreaks were detected and declared versus looking back. So I don't know if Caroline, you want to take that, or Mike, but welcome your insights.
Probably the long-term care data is more robust in that regard. So Mike, go ahead.
Sure. Yeah, thanks, Leanne. And I should mention we've posted a preprint to the work. So if people want to scour it further, it's on medRxiv. So in general, for the sites where we had that data, where we were swabbing beforehand, at some homes, we could see it more than 10 days in advance. So more than 10 days before an outbreak was detected, we could see very high rates of SARS-CoV-2 being detected on the floor. To give like an average, it's hard to give an average, but I would say on average, probably a week or so. Yeah.
Thanks. Good question. So we have a more general question about how long we can expect the virus SARS-CoV-2 to survive on surfaces.
Caroline.
Yeah, so I would just say that, you know, we're picking up viral RNA. So we have no idea if this is live virus or dead virus or exactly how long it's been there. Certainly in our manuscripts, we've got, you know, clearly the cleaning protocols are outlined and, you know, in accordance with provincial standards and all that sort of thing. So, you know, we certainly in no way want to give the impression that humans are acquiring COVID from surfaces or from the floors. I think, you know, there's, you know, that's not what we're saying. We're saying that the floor is a sink for the virus, and the floor is a marker for human transmission that's going on in that environment. So we don't know from our study.
Yeah. And I will mention that there are quite a few studies that have answered the question, if you clean the surface and check right after, is the virus still there? So there's pretty good data to show that after you've cleaned the surface, that you can no longer detect the virus right after, because I think a burning question that comes up is, well, maybe you've just detected something from weeks ago or months ago.
Thanks for that question. And I think it elicited some of the really important nuance around interpreting your findings that you just characterized really nicely. I'll just go to quite a similar question from another attendee. So they asked also about how long you can expect the virus to remain on in the environment, but then you know, how do you know whether you're simply detecting some virus particles from the previous day? So I think, Mike, you've addressed it, but just want to welcome any additional comments that you have.
Yeah, and I think also what we sort of nicely show at some of the LTCs is that it's not as though for the sites that weren't an outbreak, we're always detecting the virus, right? Like in that sort of LTC number 1, we could see, hey, there's a little bit of virus. Oh, and there's a staff case. And then next week, there's no more virus. So I do think these results are sort of sensitive enough, especially to the cleaning protocol, so that it's not just a remnant of what's gone on weeks or months ago. Yeah.
Yeah, just on that, like, so why it was so important that we needed to know staff cases versus resident cases, or of course the residents are going to stay there when they have COVID, and unlike in the hospital where they were even moved, they were often staying in their own rooms, in their own floors. So we would often see little spikes of floor positivity when there were positive staff, but then of course those staff are removed from the environment. They're not coming to work when they're positive, and so then it would go right back down. So those bigger, more sustained, higher positivity weeks were often due to like outbreaks amongst residents rather than staff. So there just is an important distinction there.
Thank you for those helpful comments. So there is a question about whether either of our speakers have comments or advice about the scalability of implementation. And I know that you mentioned, Mike, that you are looking to do more research to inform implementation, I believe specifically in the LTC setting. But the question is about how do you assess or test the scalability of implementation in a range of settings, and included, they've mentioned LTCs, educational settings, et cetera. So how would you pursue more research on that?
Yeah, so it's a great question. I think, as we were alluding to, we now want to answer the more like knowledge translation piece. If we give people this information, how will they act on it? And could that reduce the size and scope of an outbreak? So part of the work we've been doing is, how do we improve our logistics? So how do we go from you swab the floor and then you get the result really quickly in the lab, and then also you have robust data systems in place to then show that to your end user. So I think we've like really refined our logistics such that we can get results within about 48 hours of the floor being swabbed, which is similar to wastewater. And I think the work that we're doing right now in the Ottawa Hospital and the Sioux Area Hospital, again, will give a lens towards, all right, so when you're doing these knowledge translation studies, is it improving outcomes? But the honest answer for scalability, you need robust funding. Okay, like wastewater surveillance, I think got their second bucket at $20 million, which is amazing. But that's the type of money that you need if you really want to scale this. We also meet with the long-term care home partners to sort of, try to advocate to also support this work. But I think it's hard to do that. So from a scalability standpoint, it's really about getting the funding in place. And that's why we're resubmitting to CIHR. And a lot of that grant is also going to be focusing on knowledge translation and increasing more sites.
Thanks, Mike. I'm going to go to another question about interpreting the findings or more granularity on the findings from NCCEH, who asks, were there any instances where high positivity of floor swabs did not result in an outbreak?
Yeah, that's a great question. So at least from the long-term care homes, there hasn't been a scenario, for example, and you can see it from the sort of positive predictive value data where it's more than 70%, more than 80%, and there isn't an outbreak. Sometimes when we were doing the swabbing in real time or near real time, and we hadn't heard from the home that there was an outbreak, we thought, oh, shoot, maybe actually this is all a lot of remnant virus. And then later we realized, nope, there was an outbreak indeed. So there hasn't been a scenario, especially if it crosses that sort of 70% threshold, where you don't identify an outbreak, or at the very least a large number of staff cases. With the grain of salt that this is at 10 long-term care homes over 1 year. So certainly false positives could always be possible, but we haven't come across that yet.
Thanks for the question and for the answer. So I'll ask a few questions about your take on the implications of the study. So one of them from Ajax says, given floor findings in these settings, what are your thoughts on additional source controls in these settings? That's how I'll paraphrase it.
Caroline, you are the IPAC physician, so I'll let you take that one first.
Not entirely. Helping support. So, this is the thing that I'm asked about the hospital, because right now we are doing this QI study in healthcare worker only areas, both masked areas and unmasked areas. So unmasked areas like break rooms and masked areas like nursing stations, meeting rooms. And we are actually finding like quite high percentages of floor swab positivity. And so the QI part of it is that we're actioning that with rat testing for all staff who work on that unit. But what I'm always asked is, should we be cleaning the floors better or more often or more frequently or something like that? And I just would reiterate that I think that it's the finding it on the floor. It means we have to go looking for it in the people. Some of you may be aware that in, I think about January of this year, the definition for a nosocomial case of COVID among healthcare workers changed. So because the community rates were so high, that the assumption is more that it's, a community acquisition rather than a hospital acquisition, which was the opposite prior to January. But so what we're really trying to do is, is find those asymptomatic or pre-symptomatic staff, find that they're positive and, have them isolate before there can be ongoing transmission. And that's sort of the chain that we're trying to break. It's a fairly new QI study, and so I don't have a lot of results, but we are finding like surprisingly high rates of positivity in these healthcare worker only areas. I think it really just reflects the fact that in the last number of weeks, we've had really high rates of community cases. And now that that's coming down, I hope to see the floor swab positivity coming down as well. So, additional, source control and that sort of thing. So we have universal masking within the hospital, certainly within clinical areas, but we are also looking at these areas where healthcare workers have to remove their masks, such as to eat in break rooms. But even in the masked areas, and I see there's other questions about masking down below, even in the masked areas, there's still high rates of floor swab positivity.
The only other thing I'll mention as well, because we get these questions from the long-term care homes, like, what could we have done differently? Should we have cleaned the floors more? And we try to reassure, like, nope, that's not where our focus necessarily needs to be. But the other aspect is, what can we do to keep long-term cares open? Obviously, there are tremendous mental health consequences of having residents of long-term care homes constantly on isolation with no interaction and no social activities. So I think the other aspect of this, not just can you rule in an outbreak, can you rule it out? Okay, let's keep the communal activity on the 4th floor of the long-term care home, because there is no SARS-CoV-2 that we're detecting from the floor, as opposed to, oh shoot, on the 1st floor we're seeing 90% of swabs coming back positive. So I hope that it will also maybe be helpful to keep things open, if you will.
Thank you. So there are a couple of questions related to it. I think the discussion that's come up with the last question. So I'll go back to them. So a couple of questions from Anne-Marie Nickel. Was this work done when masking was required by staff, or were you able to look at the data prior to masking and after? So I think this is in the context of the study being conducted in some of your work being conducted in 2020 that you referred to, but I'll let Caroline elaborate there.
Yeah, even in that very early study in the fall of 2020, we had universal masking of staff throughout the study period. Yeah.
And then we have a question from Danielle in Simcoe around the potential KT, I think, of this work that perhaps you're looking into in your QI study. Caroline, do you see the surface swabbing as leading to testing of residents or staff for case identification and or more IPAC measures being implemented to prevent further transmission and potential outbreak declaration?
Yeah, I think those are all the really great questions that we're now needing to explore. So, as pure, when we were doing pure research projects, we we did provide information to the homes, but we did not tell them what to do with it, because really there's no public health guidance around what to do when you find SARS-CoV-2 RNA on the floor. But these are really important discussions, and in fact, this is one of the things that we hope to get from this broader audience in this forum with Public Health Ontario is, given that we can see that a few weeks before an outbreak is declared, we're finding like a high floor swab positivity. What should those measures be? So should it be, cohorting or testing or surveillance or something like that, in addition to whatever is normally going on? And just like Mike said, we hope that it works in the reverse as well. So we hope that, the entire home doesn't need to necessarily have those enhanced measures before there are human cases detected, but maybe it could be very targeted because of the spatial refinement of this technique.
Thanks so much, Caroline, and really interesting questions to explore. And I think layered onto that nuanced risk communication that you're doing today around how not to overinterpret the results that you do have, or what you can and cannot infer about transmission. So maybe I'll go to a related question about what you would. So the question is, what would you expect as far as upstream interventions in a setting such as a school? If floor swab positivity were to go up in that setting, what would the layers of prevention that you would be thinking about exploring, or are you there yet?
I would probably say great question. We're not there yet. We have been swabbing in schools and in daycares, and we look forward to sharing those data as well. I think it's hard because, again, we don't have the granular data of knowing, okay, we know how many swabs come back positive, but we don't know exactly how many kids in that school or in that classroom had COVID. So it's going to be hard to draw inferences. I should also note that we've just received a grant from COVARNet to continue the school's work. So it's crazy to think that it's almost September, but we will be swabbing in schools in the Ottawa area coming soon.
I mean, the really difficult thing that we ran into was, of course, for hospital inpatients and for long-term care residents, we can have that granular case data, but for the general public, including in schools and daycares and that sort of thing, once the testing eligibility changed dramatically in the province, there was nothing to correlate with. So if we found it on the floor in a classroom, we don't necessarily know what that means or if it correlates with cases. So what we've been trying to correlate are wastewater data and absenteeism data.
Thanks, Mike. Did you have anything to add? You're unmuted. I just want to give you the chance. No? Okay, great. So there is a broad question about what areas of the data do you wish you could study further? I think, you started talking about that at the end of your component, Mike, and Caroline, you're just talking a little bit about some of the next steps in terms of other settings, but just a chance for you to describe where you'd like to go with this research.
Yeah, I think for the other data that we sort of wish we had, certainly in the university setting, in the school setting, it would be ideal to know the ground truth information. That would be critical. Also, I think answering the question of if you have wastewater data as well, does wastewater data actually trump what you're seeing, or is it complementary? I believe it's complementary because for the most part, wastewater data is on a municipal level or a regional level. So I think there can be, those two can be complementary, and that's something we're going to be exploring in that COVARNet work. So we'll have access to both wastewater and floor swab data. So I think that'll be pretty exciting. And then also it would be terrific to know what exact variant is it on the floor. And I see that somebody asked that in the chat. We're working towards that. Right now it's sort of a binary yes or no, can you detect it? I am not a lab person, so I'm not the best person to talk about this, but it's a whole other ball game when you want to know what exact variant it is. And that sort of genomic work is an area for future research, which I think will be exciting as well. I think we've talked about most of the knowledge translation that we want to do, especially in LTCs. I also think it could be cool as like a sentinel surveillance. Maybe we should be swabbing airports. Maybe we should be swabbing areas in the community to actually get a sense of sort of, what's coming in. But those are pie in the sky ideas, at least for now.
Thank you very much, Mike. We have comment from Kara, who expresses interest in thinking about how this environmental swabbing might be layered with data on hand hygiene, PPE, environmental service audits to determine gaps. So I wonder if that's another direction that your team has discussed or considered in terms of the actual assessment of IPAC practices.
Yeah, no, I mean, I think those are all like fantastic ideas actually to try to layer into these quality improvement projects that we have ongoing in the SU and at the Ottawa Hospital, because it's actually like in the last couple of months, it's actually been, because the community levels have been so high. I mean, everyone's well aware with news reports and media that all hospitals are kind of in staffing crisis, partly due to staff with COVID. So, it's not terribly unexpected that we have these high levels of floor swab positivity, and then we're also having, high numbers of staff with COVID. I think when things settle down, hopefully when things settle down a little bit, and we can actually start to find places where we're not finding floor swab positivity, and then versus places where we are finding floor swab positivity, and what are the differences and where the gaps might be. Thank you. I'll take those into consideration.
Thank you for that answer, Caroline. So we don't have any more new questions in the Q&A chat, so I'll just emphasize this is still an opportunity if there are any additional questions and you want to share them. But I did have a question about the broader landscape of research in this area. Are there other academic centers exploring this? Are there other jurisdictions that are using this? What's your sense of where this fits into the broader literature on this innovative area of interest?
Yeah, it's a great question, Leanne. Maybe I'll start. So there's a group in South Korea that's been quite active in this area, as well as at least two groups in the US. I think what sort of differentiates the work done to date. So a lot of the work done to date has been, like you can find the virus here and there and there. Less of it pertains to like, how does it actually correlate with staff level cases? So most of the work so far has been swabbing in hospitals, some work in community settings and schools. I'm not aware of any studies being done in long-term care homes. But of course, I could be wrong. So I think thus far, our work has been a big contribution to that space. And then the fact that we also have like CO2 data, looking at ventilation. We recently partnered with architects as well to understand how does the built environment correlate and play with the results. And fingers crossed. And now with this QI work and knowledge translation work, I think that will be hopefully new and informative, because that is the burning question, is this actionable? So I think that's sort of how we kind of fit into the landscape of this type of environmental surveillance.
Yeah, and I would just say, especially with this COVARNet funding that's in the works, we'll be able to also work more closely with some of the wastewater groups. And I mean, I'm fortunate that here in Ottawa, we've got, some of the leading wastewater groups in Canada, the world. So we're going to be able to kind of zero in on certain neighborhoods where we have wastewater data, where we'll be able to do swabbing of like schools and community centers and hospitals, just to see how that all fits together along with the case data.
So thank you so much for the chance to have a lovely extended Q&A and discussion portion in addition to your very informative presentations today. Dr. Caroline Knott and Dr. Michael Fralick, we really appreciate your time and expertise, and want to thank everyone else who joined us for today's session and contributed very good questions. For those of you who are interested in PHO's learning events, please do stay tuned on the PHO website, education and events, for upcoming opportunities. For today's session, you can expect to receive a brief and anonymous PHO round survey, and we do really appreciate your input to help us improve the programming that we offer. And just to reiterate that access to past rounds presentations will be posted on the PHO website, as well as information about upcoming sessions. So head to the PHO website, then navigate over to Education and Events, and there is where you can find previously posted presentations. So thank you again to our speakers, and thank you to all of you for your time. Hopefully everyone has a wonderful afternoon, and look forward to seeing you at the next PHO rounds.